Cardiovascular disease is a class of diseases that involve the heart or blood vessels. Cardiovascular disease includes coronary artery diseases such as angina and myocardial infarction. Other CVDs are stroke, hypertensive heart disease, rheumatic heart disease, cardiomyopathy, atrial fibrillation, congenital heart disease, endocarditis, aortic aneurysms, peripheral artery disease and venous thrombosis. The underlying mechanisms vary depending on the disease in question. Coronary artery disease, stroke, and peripheral artery disease involve atherosclerosis. This may be caused by high blood pressure, smoking, diabetes, lack of exercise, obesity, high blood cholesterol, poor diet, and excessive alcohol consumption, among others. High blood pressure results in 13% of CVD deaths, while tobacco results in 9%, diabetes 6%, lack of exercise 6%, and obesity 5%. Rheumatic heart disease may follow untreated strep throat. It is estimated that 90% of CVD is preventable. Prevention of atherosclerosis is by decreasing risk factors through healthy eating, exercise, avoidance of tobacco smoke and limiting alcohol intake. Treating high blood pressure and diabetes is also beneficial. Treating people who have strep throat with antibiotics can decrease the risk of rheumatic heart disease. The effect of the use of aspirin in people who are otherwise healthy is of unclear benefit. The United States Preventive Services Task Force recommends against its use for prevention in women less than 55 and men less than 45 years old. However, in those who are older it is recommended in some individuals. Treatment of those who have CVD improves outcomes. Cardiovascular diseases are the leading cause of death globally. This is true in all areas of the world except Africa. Together they resulted in 17.3 million deaths in 2013, up from 12.3 million in 1990. Deaths, at a given age, from CVD are more common and have been increasing in much of the developing world, while rates have declined in most of the developed world since the 1970s. Coronary artery disease and stroke account for 80% of CVD deaths in males and 75% of CVD deaths in females. Most cardiovascular disease affects older adults. In the United States, 11% of people between 20 and 40 have CVD, while 37% between 40 and 60, 71% of people between 60 and 80, and 85% of people over 80 have CVD. The average age of death from coronary artery disease in the developed world is around 80, while it is around 68 in the developing world. Disease onset is typically 7 to 10 years earlier in men as compared to women. Types. There are many cardiovascular diseases involving the blood vessels. They are known as vascular diseases. Coronary artery disease. Peripheral arterial disease, disease of blood vessels that supply blood to the arms and legs. Cerebrovascular disease, disease of blood vessels that supply blood to the brain. Renal artery stenosis. Aortic aneurysm. There are also many cardiovascular diseases that involve the heart. Cardiomyopathy, diseases of cardiac muscle. Hypertensive heart disease, diseases of the heart secondary to high blood pressure or hypertension. Heart failure. Pulmonary heart disease, a failure at the right side of the heart with respiratory system involvement. Cardiac dysrhythmias, abnormalities of heart rhythm. Inflammatory heart disease, endocarditis, inflammation of the inner layer of the heart, the endocardium. The structures most commonly involved are the heart valves. Inflammatory cardiomegaly, myocarditis, inflammation of the myocardium, the muscular part of the heart. Valvular heart disease. Congenital heart disease, heart structural malformations existing at birth. Risk factors. There are several risk factors for heart diseases. Age, gender, tobacco use, physical inactivity, excessive alcohol consumption, unhealthy diet, obesity, family history of cardiovascular disease. raised blood pressure, raised blood sugar, raised blood cholesterol, psychosocial factors, poverty and low educational status, and air pollution. While the individual contribution of each risk factor varies between different communities or ethnic groups, the overall contribution of these risk factors is very consistent. Some of these risk factors, such as age, gender or family history, are immutable. However, many important cardiovascular risk factors are modifiable by lifestyle change, social change, drug treatment and prevention of hypertension, hyperlipidemia, and diabetes. Age is by far the most important risk factor in developing cardiovascular or heart diseases, with approximately a tripling of risk with each decade of life. Coronary fatty streaks can begin to form in adolescence. It is estimated that 82% of people who die of coronary heart disease are 65 and older. At the same time, the risk of stroke doubles every decade after age 55. Multiple explanations have been proposed to explain why age increases the risk of cardiovascular heart diseases. One of them is related to serum cholesterol level. In most populations, the serum total cholesterol level increases as age increases. In men, this increase levels off around age 45 to 50 years. In women, the increase continues sharply until age 60 to 65 years. Aging is also associated with changes in the mechanical and structural properties of the vascular wall, which leads to the loss of arterial elasticity and reduced arterial compliance and may subsequently lead to coronary artery disease. Sex: men are at greater risk of heart disease than premenopausal women. Once past menopause, it has been argued that a woman's risk is similar to a man's, although more recent data from the WHO and UN disputes this. If a female has diabetes, she is more likely to develop heart disease than a male with diabetes. Coronary heart diseases are 2 to 5 times more common among middle-aged men than women. In a study done by the World Health Organization, sex contributes to approximately 40% of the variation in sex ratios of coronary heart disease mortality. Another study reports similar results, finding that gender differences explains nearly half the risk associated with cardiovascular diseases. One of the proposed explanations for gender differences in cardiovascular diseases is hormonal difference. Among women, estrogen is the predominant sex hormone. Estrogen may have protective effects through glucose metabolism and hemostatic system, and may have direct effect in improving endothelial cell function. The production of estrogen decreases after menopause, and this may change the female lipid metabolism toward a more atherogenic form by decreasing the HDL cholesterol level while increasing LDL and total cholesterol levels. In the very elderly, age-related large artery pulsatility and stiffness is more pronounced among women than men. This may be caused by the women's smaller body size and arterial dimensions, which are independent of menopause. Tobacco: cigarettes are the major form of smoked tobacco. Risks to health from tobacco use result not only from direct consumption of tobacco, but also from exposure to second-hand smoke. Approximately 10% of cardiovascular disease is attributed to smoking. However, people who quit smoking by age 30 have almost as low a risk of death as never smokers. Physical inactivity: insufficient physical activity is currently the 4th leading risk factor for mortality worldwide. In 2008, 31.3% of adults aged 15 or older were insufficiently physically active. The risk of ischemic heart disease and diabetes mellitus is reduced by almost a third in adults who participate in 150 minutes of moderate physical activity each week. In addition, physical activity assists weight loss and improves blood glucose control, blood pressure, lipid profile and insulin sensitivity. These effects may, at least in part, explain its cardiovascular benefits. Diet: high dietary intakes of saturated fat, trans fats and salt, and low intake of fruits, vegetables and fish are linked to cardiovascular risk, although whether all these associations are a cause is disputed. The World Health Organization attributes approximately 1.7 million deaths worldwide to low fruit and vegetable consumption. The amount of dietary salt consumed is also an important determinant of blood pressure levels and overall cardiovascular risk. Frequent consumption of high-energy foods, such as processed foods that are high in fats and sugars, promotes obesity and may increase cardiovascular risk. High trans fat intake has adverse effects on blood lipids and circulating inflammatory markers, and elimination of trans fat from diets has been widely advocated. There is evidence that higher consumption of sugar is associated with higher blood pressure and unfavorable blood lipids, and sugar intake also increases the risk of diabetes mellitus. High consumption of processed meats is associated with an increased risk of cardiovascular disease, possibly in part due to increased dietary salt intake. The relationship between alcohol consumption and cardiovascular disease is complex, and may depend on the amount of alcohol consumed. There is a direct relationship between high levels of alcohol consumption and risk of cardiovascular disease. Drinking at low levels without episodes of heavy drinking may be associated with a reduced risk of cardiovascular disease. Overall alcohol consumption at the population level is associated with multiple health risks that exceed any potential benefits. Socio-economic disadvantage: cardiovascular disease affects low and middle-income countries even more than high-income countries. There is relatively little information regarding social patterns of cardiovascular disease within low and middle-income countries, but within high-income countries, low income and low educational status are consistently associated with greater risk of cardiovascular disease. Policies that have resulted in increased socio-economic inequalities have been associated with greater subsequent socio-economic differences in cardiovascular disease, implying a cause and effect relationship. Psychosocial factors, environmental exposures, health behaviors, and healthcare access and quality contribute to socio-economic differentials in cardiovascular disease. The Commission on Social Determinants of Health recommended that more equal distributions of power, wealth, education, housing, environmental factors, nutrition, and healthcare were needed to address inequalities in cardiovascular disease and non-communicable diseases. Air pollution: particulate matter has been studied for its short and long-term exposure effects on cardiovascular disease. Currently, PM2.5 is the major focus, in which gradients are used to determine CVD risk. For every 10 micrograms per cubic meter of PM2.5 long-term exposure, there was an estimated 8 to 18% CVD mortality risk. Women had a higher relative risk for PM2.5-induced coronary artery disease than men did. Overall, long-term PM exposure increased rate of atherosclerosis and inflammation. In regards to short-term exposure, every 25 micrograms per cubic meter of PM2.5 resulted in a 48% increase of CVD mortality risk. In addition, after only 5 days of exposure, a rise in systolic and diastolic blood pressure occurred for every 10.5 micrograms per cubic meter of PM2.5. Other research has implicated PM2.5 in irregular heart rhythm, reduced heart rate variability, and most notably heart failure. PM2.5 is also linked to carotid artery thickening and increased risk of acute myocardial infarction. Tests: coronary artery calcification, carotid total plaque area, elevated low-density lipoprotein P, elevated blood levels of brain natriuretic peptide. Pathophysiology. Population-based studies show that atherosclerosis, the major precursor of cardiovascular disease, begins in childhood. The pathobiological determinants of atherosclerosis in youth study demonstrated that intimal lesions appear in all the aortas and more than half of the right coronary arteries of youths aged 7 to 9 years. This is extremely important considering that 1 in 3 people die from complications attributable to atherosclerosis. In order to stem the tide, education and awareness that cardiovascular disease poses the greatest threat, and measures to prevent or reverse this disease must be taken. Obesity and diabetes mellitus are often linked to cardiovascular disease, as are a history of chronic kidney disease and hypercholesterolemia. In fact, cardiovascular disease is the most life-threatening of the diabetic complications, and diabetics are 2 to 4-fold more likely to die of cardiovascular-related causes than non-diabetics. Screening ECGs are not recommended in those without symptoms who are at low risk. This includes those who are young without risk factors. In those at higher risk, the evidence for screening with ECGs is inconclusive. Additionally, echocardiography, myocardial perfusion imaging, and cardiac stress testing is not recommended in those at low risk who do not have symptoms. Some biomarkers may add to conventional cardiovascular risk factors in predicting the risk of future cardiovascular disease. However, the clinical value of some biomarkers is questionable.